I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. For decades, chronic fatigue syndrome was dismissed as psychosomatic. Long COVID has changed everything. This is the People's Pharmacy with Terry and Joe Graydon.
Millions of Americans who were infected with SARS-CoV-2 are now suffering from long COVID. There are over 200 symptoms associated with this condition, including chronic fatigue.
Modern medicine has a hard time dealing with a condition that has so many different symptoms and no clear treatment. That leaves both patients and physicians frustrated.
What is the latest research on the possible causes of post-acute sequelae of COVID? Does the virus persist in the body?
Coming up on the People's Pharmacy, grappling with the mysteries of long COVID.
In the People's Pharmacy Health Headlines, COVID is back. Actually, it never went away, but cases are rising across the country. According to the CDC, virus levels in 26 states are categorized as high or very high based on wastewater surveillance. California, Nevada, and Oregon are all at very high levels, and so are Texas and Florida. No states are reporting a decline, although emergency rooms are not overwhelmed. The variants causing the most infections are KP3 and KP2, which are mutations from Omicron. Many of the symptoms are similar to other respiratory tract infections: sore throat, cough, congestion, runny nose, fatigue, muscle aches, and headache. GI symptoms, fever, and trouble breathing may also be present. One explanation for the increasing cases is holiday travel and exceptionally hot weather driving people inside to escape the heat.
Most people are trying hard to ignore bird flu. The last thing we want to think about is another pandemic, and yet public health workers are starting to worry about the spread of bird flu among agricultural workers. Human cases are increasing. Several people who work on poultry farms are reporting symptoms such as pink eye, cough, sore throat, runny nose, fever, and shortness of breath. Some cases of H5N1 have been reported in dairy workers. It remains to be seen whether the virus will become easily transmitted from person to person.
A lot of people are anxious about developing cancer. A poll in the UK found that 2/3 of those queried are very worried that they will get a cancer diagnosis. Many were concerned that they would not be able to get the right treatment or that the treatment would have devastating side effects. A new study shows that in the U.S., about 2/5 of new cancer cases among adults can be attributed to preventable risk factors. The most prominent is smoking, which contributes to nearly 1/3 of all deaths from cancer. Sedentary lifestyle, excess alcohol consumption, and obesity also contribute to the toll from cancer. Diets that are high in red and processed meats and low in vegetables and fruits appear to make people more susceptible as well. Ultraviolet radiation and infections with carcinogenic pathogens such as HPV were also named. Lung cancer contributes the most to preventable cancer mortality, with colorectal, liver, and esophageal cancers also causing large numbers of deaths.
Air pollution, especially that caused by fine particulate matter, is responsible for a significant amount of cardiovascular and respiratory disease. A new study published in JAMA Network Open suggests that air pollution can also contribute to inflammatory skin problems, in particular psoriasis. The investigators reviewed data from nearly 500,000 individuals who participated in the UK Biobank. Air pollutants were associated with an increased risk of psoriasis. People with a genetic predisposition were especially vulnerable if they were exposed to fine particulate matter, nitrogen dioxide, and nitrogen oxides. The longer the exposure, the greater the risk. An editorial that accompanies the research suggests that the skin microbiome may be altered by air pollution. That in turn could lead to oxidative stress and increased inflammatory reactions. Unfortunately, clinicians do not yet know what to recommend for people whose psoriasis may be linked to a genetic predisposition and air pollution. Because climate change is likely to make air quality worse, dermatologists need to learn how to best protect and treat patients with pollution-sensitive inflammatory skin diseases.
Common environmental toxins are linked to symptoms of depression. Researchers found 27 common environmental compounds that were associated with depressive symptoms. They included nicotine metabolites, volatile organic compound metabolites, acrylamide, ethylene oxide, and heavy metals. Chronic systemic inflammation might be the link between toxins in the environment and depressive symptoms. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Experts estimate that around 18 million Americans have been suffering with symptoms of long COVID. That's roughly 7% of the adult population.
In many ways, post-acute sequelae of COVID, or PASC, remain something of a mystery. It affects a multitude of organ systems and produces symptoms that range from COVID cough and chest pain to shortness of breath and brain fog.
But one of the most debilitating aspects of long COVID is the overwhelming fatigue that makes it hard to function.
To learn more about the long-term effects of COVID-19, we turn to Dr. Lisa Sanders. She's the medical director of Yale's Long COVID Multidisciplinary Care Center. In addition to her work as a physician and teacher, she writes the popular diagnosis column for the New York Times Magazine. In 2019, Dr. Sanders collaborated with the New York Times on an 8-hour documentary series on the process of diagnosis for Netflix. Dr. Sanders is the author of Every Patient Tells a Story and Diagnosis, Solving the Most Baffling Medical Mysteries.
Welcome back to the People's Pharmacy, Dr. Lisa Sanders.
Thanks so much, Terry, for having me back.
Dr. Sanders, you've kind of made a detour in your career in the last year or two. Can you tell us a little bit about how you've ended up becoming head of this multidisciplinary care group dealing with long COVID at Yale?
Well, yes, this is very exciting for me. I heard that Yale was trying to start a long COVID clinic. I heard it from one of the several doctors who saw most of the long COVID patients at Yale. She's a cardiologist, and so people who have palpitations or tachycardia were going to her. There were also 2 pulmonologists, so people who were short of breath or had a cough or those kinds of things were going to them. And then there was this wonderful neurologist, and everybody who had brain fog or fatigue went to her. And they thought, first, this does not require subspecialty work most of the time. And second, most of these patients had more than one symptom. I mean, they might have had palpitations, which sent them to the cardiologist, but they were also short of breath, and they were also tired, and they also had brain fog. So it was clear to them that this was a disease that crossed all kinds of specialties, and they thought that having a clinic, a one-stop shop, where they could have all of their needs addressed or at least looked at, would make more sense. And so Yale decided to open a clinic. And as soon as I heard about it from the cardiologist, Erica Spatz, I was immediately interested because I'm a primary care doctor. I've been a primary care doctor for over 20 years. But to me, this idea, this disorder was something that was quote unquote new. I mean, we hadn't had COVID before. But it was also old. I had seen so many patients and read about and been in touch with so many patients who had post-infectious syndromes of some variety. And I was really, really interested in being part of an effort to figure these things out, to see what we could do for this group of patients who often got kind of blown off by their doctors because doctors didn't know what to do about it. So we started this clinic, and we have respiratory therapy, we have social work, we have physical therapy, and then we have, me, the medical person, and I work with a PA who's also just fantastic.
That sounds great. And I'm thinking that your interest in diagnostic puzzles may also have played a role here, because at least at the beginning, people with long COVID faced difficulties having anyone sort of say, well, we know what's wrong with you. We still don't exactly know what's wrong with them, other than this sort of general category of long COVID, or as you put it, post-infectious syndromes, do we?
We really don't understand them very well at all. I mean, I think we're getting better. And dare I say that something good came out of COVID? I mean, it's kind of good, is that enough people got COVID and then got long COVID that we had a huge population to look at and study. I say we. I'm not a researcher. I'm a clinician. I like to help people feel better and figure out what else needs to be done. But I'm here at Yale, and there are a lot of people who are trying to figure out how this all works and what's going on with that. And I wanted to see it. I wanted a ringside seat, and I wanted to be able to help.
Well, Dr. Sanders, a lot of people think of you a bit as the Sherlock Holmes of medicine. And you did consult for the TV show House, if I'm not mistaken, in which there are always these puzzles, these challenges, these situations where everybody seems at a loss to figure out what the heck is going on. And I think if we dial back a couple of decades to the very beginning of chronic fatigue syndrome, as it was called back then, there was a lot of puzzlement. I mean, there were a lot of your colleagues back then, many decades ago, who just didn't believe there was such a thing as chronic fatigue syndrome. And it's all in their heads. It couldn't possibly be infectious. There's no sign of any problem going on. And yet now we know that there is this thing called MECFS. You can probably pronounce it better than I can. And we even know that there's this thing called long Lyme. So it seems like in your career, you've been looking for zebras rather than just horses for a very long time. You're ideally suited for this particular responsibility.
Well, thank you. That's very kind. First, I think I still feel like, even though people come to me with a diagnosis, they say I have long COVID, or my doctor thinks I have long COVID. The definition of long COVID is really vague, and there's no confirmatory test. And so when you look at the definition, it is symptoms that occur, within 3 months after having COVID, or it can be longer, but certainly after COVID, that aren't caused by anything else. And so one of the most important jobs I do is to make sure there's nothing else going on. When people come to me with chronic fatigue, or with brain fog, or with a new diarrhea, or with new asthma, my job is to make sure that there's nothing else that's causing this that can be treated more directly. I mean, to be honest, we don't know how to treat quote unquote long COVID. All we know is that people are suffering and their symptoms need to be addressed. But there are other diseases that you might have that we can treat. And so I have to make sure that what you have is this mysterious post-infectious syndrome that we call long COVID.
Can you think of an example that a person you may have seen or heard about who was thought to have long COVID but actually had something else?
Oh, absolutely. I wrote about it in my column in the New York Times. It was a mistake that I made. Somebody came to me in the long COVID clinic, and she was very tachycardic. Her heart was racing all the time, and she felt lightheaded, and she had some GI symptoms, some diarrhea. And I thought, this is totally long COVID. And so I thought she probably had postural orthostatic tachycardia syndrome, one of the autonomic nerve problems that people can have after an infection. And so I tested her for it. We do this test. Some people do a tilt table test where they basically hang you up on a table at 80 degrees and see what happens if you faint. We do it with people actually standing up for 10 minutes. And she was dramatically positive. Her heart rate raised immensely just from the effort of standing up. And I thought, aha, got it. And I treated her for POTS, and I had her come back a couple of months later, and she was no better. So when you treat somebody and they don't get better, then the very first thought you must have is, did I get this wrong? If you don't,
Yes.
If you don't think that, you're just not being honest with yourself, because that has to be the first. Sometimes the first thought is, did this patient really do this? Are they really taking their medicine? You just have to give that on faith. You can come to that. But the first thought has to be, if the treatment doesn't work, then maybe the diagnosis isn't right. So I started from the beginning. I said, tell me about all of this that's going on. And it didn't take more than 5 minutes. Once I opened up my mind, which happened on my end, and she told me the same story, and I heard it in a different light. And I realized that she didn't have long COVID. She had hyperthyroidism. And so I only ordered one blood test. I might have ordered others just because I can't help myself. But I was only interested in one result, which was, what was her thyroid doing? And of course, her thyroid was wildly out of control. And I sent her to an endocrinologist, and she's being treated. And she's fine. The treatment worked. And there was also a test showing that, that was the right diagnosis. But that happens. And, I find that exciting.
Absolutely. And I have to imagine that the patient also found it very exciting to feel better instead of to be dragging along.
You're listening to Dr. Lisa Sanders. She's the medical director of Yale's Long COVID Multidisciplinary Care Center. In addition to her work as a physician and teacher, she writes the popular diagnosis column for the New York Times Magazine. Her books include Every Patient Tells a Story, Medical Mysteries in the Art of Diagnosis, and Diagnosis, Solving the Most Baffling Medical Mysteries.
When Joe mentioned zebras, he was thinking of a saying medical students are taught. When you hear hoofbeats, think horses, not zebras. Horses are common and zebras are rare, but once in a while a person does suffer from a condition that's very unusual, if not rare. That's when the doctor shouldn't overlook zebras.
After the break, we'll find out why long COVID patients could be a doctor's worst nightmare.
With more than 200 possible symptoms, it could be dizzying to try to figure out what's wrong.
We'll also hear from a microbiologist who's been studying long COVID. She says it's still a mystery.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This podcast is made possible in part by CocoVia, maker of the most proven and concentrated flavanol extract in the market today, CocoPro, Cocoa Extract.
It's officially summer, and that means you have more time to spend outdoors, being active and creating lifelong memories. Whether you're looking to support your heart health or brain health this summer, you can achieve your goals with CocoVia. All CocoVia supplements contain the #1 proven source of flavanols, CocoPro, backed by 20-plus years of research. These powerful bioactive nutrients are clinically proven to promote cardiovascular health and improve cognitive function as you age.
Get 15% off all CocoVia products from July 15th through July 29th using the discount code SUMMER2024 at cocovia.com. That discount code again, SUMMER2024.
These statements have not been evaluated by the Food and Drug Administration. This product is not intended to diagnose, treat, cure, or prevent any disease.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible in part by CocoVia dietary supplements. This summer, keep up with your heart and brain health with cocoflavanols for a strong heart and cognitive support. Consider how CocoVia can be a part of your supplement routine. More information is available at cocovia.com.
Long COVID has been disastrous for millions of patients, but it's also challenging the medical profession. There have been no easy answers for people suffering from such a wide range of symptoms.
In a few minutes, we'll talk with a microbiologist who heads up a multidisciplinary collaboration trying to understand the causes of long COVID. But first, we continue our conversation with Dr. Lisa Sanders, Medical Director of Yale's Long COVID Multidisciplinary Care Center.
Dr. Sanders, you have written that in some ways, long COVID patients are every doctor's worst nightmare. Doctors are really pushed for time these days, and long COVID doesn't lend itself to a 10-minute meeting. Can you explain why this is such a challenge for so many of your colleagues?
Well, first, it's a multi-system disorder. So people feel bad in a lot of ways, and they want to tell you about it. And sometimes that just takes time. I mean, if you only have a 15-minute or a 20-minute visit and somebody takes up all 20 minutes telling you about all the weird things they've noticed since they had COVID, well, you don't have any time to think or prescribe or test. You just don't have time. That's part of it. But there's also a lack of training. What I tell patients is that doctors know a lot about diseases that will kill you. Because after a patient's dead, they cut you open, they do an autopsy, and then they go, oh, that's what's wrong. I mean, that's an oversimplification, but really the things that are deadly are kind of easier to understand because you can see it. The diseases that just make you feel terrible, not so easy. Not so easy, and especially ones that don't have, where we don't have a good enough understanding to identify a test to see to answer the question, is this what it is? So I think that there's a lot of knowledge gaps. So that when doctors see a patient who says, oh, I'm tired all the time. I feel like I never get enough sleep. My brain feels foggy. I feel tightness in my chest. These are symptoms, I have diarrhea. So all of a sudden there are like 4 systems that are involved and the doctor feels overwhelmed. That's hard for doctors of any variety. And these are also symptoms and disorders that we don't have great treatments for. In some ways, we're like where we were before we had any high blood pressure medicines. We could measure high blood pressure. That was easy. But there was a time when we had only a few or a couple of very mediocre blood pressure medicines, and so we relied heavily on lifestyle change. With obesity, before we had any of these magnificent drugs that we have that have their own problems, but are amazing in their own way, all we had was lifestyle. So with things like ME/CFS, chronic fatigue syndrome, or, brain fog, we don't have pills that will make you better. All we have are lifestyle things. For people who have brain fog, the most effective thing I can do is send them to a speech therapist for something known as cognitive rehabilitation. This is something that has been done for people who have had all kinds of brain injuries, because I think of COVID as being kind of a neurologic injury. So people who've had strokes or chemotherapy, had chemo brain, or trauma to their brain, they go through this cognitive rehabilitation, and it helps them use the brain that they have better. So, or with fatigue, chronic fatigue syndrome. I mean, it's all lifestyle. We don't have medicines that make you less tired. I mean, sure, I could put you on an amphetamine, and then you would be, what my patients have told me is wired but tired. I mean, you're still tired. You're awake, but you're still tired. I mean, so there are not a lot of great therapies. There are not a lot of great tests. And so doctors are understandably frustrated by this.
We've heard that there are like as many as 200 symptoms or more associated with COVID. Now, of course, there's a handful that are very common, but there are some that are kind of out there on the borders. And I'm just wondering, how does a clinician, family practice physician, internist, how does that health professional begin to parse all of these different symptoms that literally can be very different? There's the brain, there's the cardiovascular system, there's the hormonal system, there's the digestive tract. How do you coordinate something like that if you're not at a center like yours at Yale?
Well, I think you have to be interested. I think that's an important thing. And I think that having some familiarity with what long COVID looks like is also important. And then I think you have to be curious. That's also important. And then you have to be open to the possibility that even though this patient had COVID and thinks they have long COVID, that maybe it's not long COVID. Maybe there's something else going on. You have to be open to all of these things. And, it's not every doctor's everyday experience. When I was a primary care doctor, which I loved, I would have patients who I would see for their diabetes. So I knew what they had. I knew what the therapies were. Not everything works for everybody, so you have to try to work with who you have and what they've got and what they're taking. But the answers are all right there. It's not so true with long COVID. I mean, the good thing about long COVID is mostly patients with long COVID don't die. They're very sick. They feel terrible, but fortunately, most of them don't die. So you're not dealing with a deadly disease, but that doesn't mean there's no suffering. There's so many ways to suffer.
It seems as though it must be a very frustrating experience, both for the healthcare provider and for the patient and the patient's family. A syndrome like this that has so many different possible ways of making you feel bad and so few clear ways of helping you feel better affects everyone in the family.
Oh, it's true. And so many of my patients either had to cut back at work or stop working for a while. I mean, and it's not just my patients. I mean, when you look at the studies, you see that I can't remember what the statistic is, but it's between 20 and 30% of patients who have long COVID are unable to work, or at least unable to work full time. So it can be quite crippling, very hard on patients and very hard on their families. They look fine, but they can't be fine. And so I think it's frustrating for patients, and I think it's very frustrating for their families. And doctors, they just don't know about this. I mean, there's so much to know about as an internist. There's so many things to know about in internal medicine and in primary care that nobody is an expert in everything. We try, but nobody's an expert in everything. And so it's hard for doctors to really know what to do. And there's not a lot, in some cases, there's not a lot to be done. But I think there's something that's useful about just acknowledging that this probably is long COVID and that we've seen other patients who have symptoms like yours, and this is what has been shown to be helpful for them. That's where we are.
Dr. Lisa Sanders. Thank you so much for talking with us on the People's Pharmacy today.
Well, thanks so much, Terry. Thanks, Joe. Take care.
You've been listening to Dr. Lisa Sanders. She's the medical director of Yale's Long COVID Multidisciplinary Care Center. She writes the popular Diagnosis column for the New York Times Magazine. Her books include Every Patient Tells a Story, Medical Mysteries in the Art of Diagnosis, and Diagnosis, Solving the Most Baffling Medical Mysteries.
We turn now to Dr. Amy Proel, a microbiologist who studies the molecular mechanisms by which bacterial, fungal, and viral pathogens dysregulate human gene expression, immunity, and metabolism. Dr. Proel is the founder of the PolyBio Foundation and the chief science officer and co-founder of the Long COVID Research Initiative. We think you'll find what she has to say very interesting, but we apologize in advance for the quality of the sound. The electronic connection was not strong when we recorded this interview, and you will hear some dropouts.
Welcome back to the People's Pharmacy, Dr. Amy Proel.
Thanks for having me back on.
Dr. Proel, I think that we are now past 4 years with COVID-19, and yet there's still so much we don't understand about this virus. Long COVID is a mystery. I mean, it has so many symptoms. I think at last count it's somewhere over 200, and we have no good way to diagnose it. That is to say, many people have very different experiences with long COVID. Can you give us a quick summary of what we have learned about this mysterious condition over the last couple of years?
Sure. And, the interesting part is it's interesting for you to call it a mystery because to us, there's just incredibly straight, really clear leads on the drivers of long COVID. So to the research teams working in this space, I think that we see it as the opposite of a mystery. We just see very targeted research and findings. And then also even clinical trials are beginning that are already targeting some of these, prime mechanisms of long COVID. One of them being in the one that we most study and seek to treat, the straightforward fact that some patients with long COVID just don't seem to fully clear the virus. A little bit of virus persists in their tissue in what we call a reservoir. And then that persistent virus can continue to potentially provoke the immune system and drive a wide range of other problems. And a group of over 30 of us scientists wrote a paper in Nature Immunology a few months ago where we, delineate evidence for SARS-CoV-2 reservoir persistence in long COVID. We delineate mechanisms by which a SARS-CoV-2 reservoir, this persistence in tissue, can drive a range of metabolic and immune abnormalities that can account also even coagulation or clotting-based abnormalities that can contribute to long COVID symptoms. And then, a guide for the field in terms of moving forward, including clinical trials, some of which are underway. For example, there are 4 trials of the antiviral Paxlovid and long COVID in an attempt to treat persistent virus. There's at UCSF, University of California, San Francisco, there's a monoclonal antibody that's being trialed with the hope that the antibody can sort of, rejuvenate the immune response to be able to identify and clear persistently infected viral cells. There's a trial at Harvard Medical School that our nonprofit is supporting where children with long COVID are actually being given a drug that repairs, helps to repair gut permeability, which seems to prevent leakage of spike protein from persistent virus in the gut from getting into blood, which can stop some of the, persistent problems driven by the leakage of spike protein to blood. So that trial is happening at Harvard. So there's a lot of stuff going on, especially tied to persistent virus, but, due to several other, leads in the space as well.
Well, the last time we spoke, you suggested that the pharmaceutical companies have been reluctant to invest in research on long COVID because there aren't any really, or there weren't at that time, widely accepted biomarkers. Has that changed? Because it does sound, as you described the situation now, that there are a number of trials going on.
Yeah, it's improving. We can now measure, it's not perfect, but we can measure metrics of persistence in clinical trial participants. So we don't have a perfect biomarker of persistence. And The reason for that is because, as I explained, the persistence of the virus appears to be a largely tissue-based phenomenon. So in other words, someone can clear the virus from their blood, which is the most common, accessible sample type that we usually collect and measure for, clinical trials. But they could have the virus in the tissue of their gut or the tissue of their lung or in their lymph nodes or something, right? And thus, potentially, we cannot, get the virus from, understand that people have persistent virus in a trial where we're trying to target it, but there's ways around that. Some teams actually just doing tissue biopsies on patients before and after interventions in clinical trials. So that monoclonal antibody trial I mentioned, the UCSF, most of the participants actually undergo a gut biopsy procedure before they're given the monoclonal antibody. The team looks for persistent spike RNA, and they can even use a probe that actually identifies double-stranded viral RNA in the gut tissue sample, which indicates viral replication, which they're actually finding in some patients. And then they put them on the monoclonal, and then they undergo the biopsy procedure afterwards, and thus they can measure the potential clearance of the virus, via biopsy, right? Now that is, does require quite an infrastructure to be able to do. So other teams are beginning to measure metrics of persistence in more accessible fluids like blood or saliva. I mean, there are a number of studies now, including published in Lancet Infectious Diseases, a study that shows that at least some patients after COVID, about 25%, you can capture persistent SARS-CoV-2 protein in their blood at any given point, right? Now, people don't think the virus is necessarily persisting in their blood. It's more like the virus would be persisting, let's say, in the lining of the gut, but proteins that it's making, like the spike protein, leak into the blood where sometimes they can be measured. So there's teams like David Waltz at Harvard that's using, for example, this sensitive method called Simoa to measure this tiny amount of protein in long COVID blood. And there are a couple teams working with either David Waltz or with other groups that have these sensitive assays to identifying SARS-CoV-2 proteins in clinical trial participants. And there are teams that are even in some cases just measuring viral RNA, which sometimes seems to get into the blood before or after intervention. Another possibility that's being explored is RNA shedding in stool, since the gut seems to be a prime site persistence of SARS-CoV-2 in long COVID. And that's for probably a couple of reasons. One being that the gut is really dense with the ACE2 receptors that the virus uses for cell entry. So it's a tissue that the virus can easily get into. And also the virus, SARS-CoV-2, reaches the gut in a good number of people who are infected with the virus. I mean, it's just really common now for people who have COVID for SARS-CoV-2 to get into their gut. So that's this common reservoir site. And even if the virus gets into the tissue, it seems that sometimes in patients, it can continue to leak in their stool, where then the RNA from their stool can be measured over time. That's been shown in a couple of studies, right? So there are ways, they're not perfect. Like we don't have this biomarker where we can always say that we know a person has viral persistence, because obviously the virus could be persisting in their brain or a nerve or something. We might miss it. But we have these tests that are growing that allow inference of persistence, and that's enough for a lot of groups to be running clinical trials.
You're listening to Dr. Amy Proehl, a microbiologist studying the molecular mechanisms through which pathogens disrupt human biology. She's the founder of the PolyBio Foundation and co-founder of the Long COVID Research Initiative.
After the break, we'll review the concept of long COVID.
Is the virus still lurking in people's bodies? Or perhaps some remnant of the virus?
Is it reasonable to assume that people without lingering symptoms have cleared the virus?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This podcast is brought to you in part by The People's Pharmacy and our exclusive line of magnesium-rich roll-on deodorants, crafted with years of expertise and community feedback. Our customers rave about their ability to control odor effectively without aluminum. These deodorants are a superior choice for daily health and comfort.
Each is designed to be gentle yet highly effective, providing reliable odor control without aluminum or other harsh chemicals. Plus, They're incredibly easy to use and long-lasting.
As a special offer for our podcast listeners, enjoy an exclusive 20% discount on any size of our deodorant. Choose between the handy 2-ounce scented or unscented varieties, or the economical 3.38-ounce unscented version.
Simply visit the body care section in the store at peoplespharmacy.com and enter the promo code POD20, that's POD 20, during checkout to redeem your discount. Remember, this promo code POD20 gives you 20% off your purchase of our top-rated magnesium-rich, aluminum-free roll-on deodorants until August 2024.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible in part by CocoVia dietary supplements. This summer, keep up with your heart and brain health with Coco Flavanols for a strong heart and cognitive support. Consider how CocoVia can be a part of your supplement routine. More information is available at cocovia.com.
Today on the People's Pharmacy, we are grappling with the mysteries of long COVID.
We're talking with microbiologist Amy Proehl, who studies the molecular mechanisms by which bacterial, fungal, and viral pathogens dysregulate human gene expression, immunity, and metabolism. Dr. Proehl is the founder of the Polybio Foundation and the chief science officer and co-founder of the Long COVID Research Initiative. Again, we apologize for some dropouts you'll hear in the recording. The electronic connection was far from perfect, but we think you'll find the ideas discussed worthwhile.
Dr. Proehl, I think it would be helpful to go back and sort of recapture the concept of long COVID. It sounds like you've made a lot of progress, and the belief is now that the virus or viral remnants are lurking. They're somehow dormant within the system. That is to say, they're hiding in all sorts of tissues, and they may be shedding RNA. So is there active virus that's still in the body, and then there are remnants of the virus that are activating the immune system? Have I kind of got a glimmer here?
Yeah, no, that's a reasonable summary. To clarify, long COVID, there's a heterogeneous group of people that fit that diagnosis. So after COVID, there's a lot of things that can go wrong. So some people definitely just still, for example, might have like lung damage because their acute infection was so bad. And in some people, maybe the infection sinks the immune response, and then that leads to reactivation of a virus like Epstein-Barr virus or something, right? So in other words, there are multiple drivers that we're seeing in long COVID patients happening, but this persistence of the SARS-CoV-2 virus in tissue, in other words, just a failure to fully clear the virus, is definitely emerging as like a primary factor in at least a subset of patients with long COVID. And so that is the area of study and research that our consortium, our long COVID research consortium, has taken on in the greatest capacity to best understand and treat. And in that case, yes, what is happening is we're finding the RNA of the virus in different, tissues from patients after COVID. And to do that, we've actually had to have teams do studies where they do biopsy procedures to collect, let's say, gut tissue or lung tissue or lymph node tissue, for example, from patients with long COVID. And especially in the gut, there are teams, for example, finding that even up to, there's a team at UCSF that has a paper right now it's a preprint, but it should be published as a formal paper soon. And they found SARS-CoV-2 spike RNA in the gut of patients with long COVID over 600 days after initial infection. And that's the backbone of the virus there, right? And, the question is it replicating virus? That's still an ongoing research question. We're not sure, and it could differ based on patients. So, for example, in some people, potentially the virus could be persisting and replicating, and maybe in others, it's actually just more inert is RNA, and that's one of the prime things we're studying. But there are some teams that are finding signs that the virus could be replicating in long COVID. For example, there's a team in France that just presented pretty recently a poster at an HIV conference where they showed in platelets, which are in sort of red blood cells from patients with long COVID, cells involved in clotting processes. They showed double-stranded viral RNA in those platelets, and double-stranded RNA is only created when the virus replicates. So that suggests that there could be replicating virus in those platelets from those long COVID patients, right? So basically, it's a topic that's still greatly under study, and we don't even know if the virus is persisting in the exact same way in every patient. But overall, it's certainly not like what's happening is just inert. There's definitely that there could be replicating virus in some patients, and that there could also be shedding of viral proteins like spike into blood, which can drive a wide range of other downstream consequences, clotting and other issues.
It sounds as though there is the potential that a lot of people are carrying around SARS-CoV-2 in their tissues one way or another. But I'm assuming that people who don't suffer from long COVID mostly have cleared the virus. Is that a reasonable assumption?
The truth is we don't totally know. That's part of what our program is looking at, is we're actually interested in the capacity of SARS-CoV-2 persist, of course, in people who develop symptoms, but also potentially in people who don't. I mean, other viruses, for example, Epstein-Barr virus, which I mentioned before, which is a DNA virus, meaning it's, different than SARS-CoV-2 in some ways because SARS-CoV-2 is RNA virus. So they have different types of backbones. But so that Epstein-Barr virus can persist in people, in many people actually, in a kind of dormant state for a long time where it doesn't seem to drive any symptoms. And yet in certain people, it can act in ways where it does begin to drive disease. And so we don't know, honestly, that SARS-CoV-2 can't do the same thing. In other words, it could potentially silently persist in some people and potentially then drive disease at a later date, even if people don't have symptoms now. And I know that's disconcerting, but there are actually some studies that suggest that that could be happening. For example, there was a team, and this is pretty worrisome because this is children. There's a team at the NIH that got tonsil tissue from children undergoing, routine surgery to get their tonsils removed. Again, like why the kids were getting their tonsils removed is a question. Maybe they had breathing difficulties or something like that. So that could indicate some kind of issue with SARS-CoV-2 or a virus. But in this tissue obtained from routine tonsil surgeries from children, they still found SARS-CoV-2 RNA in a high portion of this tonsil tissue from children after surgery, hundreds of days in some cases after initial infection. And these were children that were not reporting any other issues. In other words, they were deemed asymptomatic, right? And so that does seed this sort of disconcerting possibility that the virus could be sticking around in tissues like the lymph nodes or other sites in people, even without symptoms. Yeah.
So it sounds to me as if this concept of what I'm going to call, for lack of a better term, long virus, not just long COVID, but long virus, because, for I think many, many decades, infectious disease experts believed that, you came down with pneumonia and you took an antibiotic and then the bacteria was gone in 2 weeks and you were cured. And so there's been this kind of belief that, all you needed was the right drug and boom, a week or two and everything's going to be fine. But we're maybe learning that there's this microbiome of viral infections, maybe in the brain, maybe in the lungs, maybe throughout the body. And they lie dormant sometimes for weeks, months, or years, and then they're reactivated. So could you give us a little sense of how this field is changing as a result of long COVID?
Yes. I mean, you're right that the sort of assumption is that when someone gets an infection and, especially often they're given some kind of treatment for it that they just fully clear the pathogen, and there's sterilizing immunity. It's what it's called. There's nothing left there. But, obviously, if people develop chronic symptoms after an infection, which happens after most, if not every, major infection. So almost every major viral infection, from dengue to Zika to Ebola, and then bacterial infections like Borrelia, the Lyme pathogen, and Bartonella, Babesia, Q fever, are connected to a syndrome like long COVID, where a certain subset of people develop chronic symptoms that just don't go away, right? And the truth is, very obvious, and that's why it's part of what we study so greatly in long COVID, a very obvious explanation would just be that they haven't fully cleared the pathogen, right? And the problem, which has made that, it's true that medicine hasn't gone in that direction as much as it could have over the past years. And one of the reasons is that it's hard to find these pathogens when they persist in a chronic state. Like I said before, the problem is that their genetic material, their RNA, is not often found in the blood, which is where people, the fluid we most use for diagnosis, right? And that's because if you're going to persist as a pathogen, the blood is kind of a dumb place to be, right? That's where the immune system is most robust. That's where you're most likely to get targeted by immune cells. So in simple terms, what the pathogens do is they hide in tissue where they're often better protected from the immune response, right? And that's what we're calling a reservoir, like a small amount of virus that's hiding out, right? And the issue then is that someone can look like they don't have the pathogen on a conventional blood test. In fact, they won't, right? And it's not until you get a piece of their tissue or you use a very specific, test that can find tiny amounts of viral protein that might leak in the blood or something that you're actually able to find the pathogen. Thus, that's kind of the conundrum in this space, is diagnosis of the persistence is really hard. And that's what we're working to try to make easier, honestly, as part of our program.
Amy, I wonder if you can tell us anything about some treatments that look promising.
Yeah. So the good thing is that there are clinical trials to try to target these SARS-CoV-2 reservoirs in patients with long COVID, and they're being run by really capable teams. So, for example, one of the teams that we work with as part of our long COVID research consortium via Polybio, where I work, is a team at University of California, San Francisco, that includes Steve Deeks and other researchers that really, their whole thing for the last decades has been HIV persistence. So HIV, the virus, can also persist in tissue reservoir sites. And that's what they've, worked to treat and to study and treat. And what they did that was really helpful for long COVID is in April of 2020, very early on, they just pivoted their infrastructure for HIV into long COVID. And that's why they started to collect the tissue samples, like gut tissue samples from patients with long COVID, where they've been able to find, persistence of the SARS-CoV-2 virus. And so some clinical trials, for example, are being run by that team. And that team has a lot of experience in running trials because of their HIV background. So they're a team, for example, they're running a monoclonal antibody trial in long COVID to try to target persistent reservoirs of the virus, with the idea being that, when you're trying to target a persistent pathogen, the thing we almost know is going to be needed that we're working towards in clinical trials are going to be combination therapies. In other words, you probably need something like an antiviral to try to, prevent viral replication or prevent spread of persistent reservoirs to new cells, right? But the thing is that might not be quite enough to fully clear the persistent RNA. So what's done, for example, with HIV is they bring in a drug like a monoclonal antibody that can also invigorate the immune system to go after the persistent virus. And so right now, there isn't a combination trial yet in long COVID, but teams are trialing antivirals like Paxlovid or Shionogi's antiviral, Encitrovir, and the monoclonal antibody Arium, for example, at UCSF, to begin these trials that are moving towards hopefully even some combination therapies. And for example, where I work, part of my time I spend as the scientific director of CORE, which is a new clinic at Mount Sinai, treating long COVID and other infection-associated chronic conditions. And we're actually running a trial of repurposed antivirals in COVID. We're taking Truvada, which is used for HIV, but appears to have some activity against SARS-CoV-2 and even in some cases Epstein-Barr virus, and Maraviroc, another HIV antiviral. And we're trialing them in long COVID as well, just to see, what kind of stuff we can get from repurposing antivirals in these patients. So there is actually a lot of movement to trial both, repurposed drugs in some of the blockbuster pharma drugs in the space. The biggest problem we face is a lack of government funding. I'll be honest with you. There's not a government funding mechanism now for clinical trials in long COVID. So it's private donors, interestingly, like those that support our foundation, that are picking up the trials in concert with sometimes some of the companies in the space, right? And that's okay. And that's kind of how it's moving. But the truth is there could be even more trials probably if there was actually a government funding mechanism for them to happen.
Dr. Proel, I have been fascinated by the idea of metronomic therapy. We had some interactions with an internist many years ago, family practice doc as well, who treated asthma with an antibiotic, what we call a macrolide, Z-Pak, but not just for a day or a week or 10 days, but for a couple of days every other week, and then for months, to try and knock out the bacteria that he thinks is causing some hard-to-treat asthma cases. Do you see a day when metronomic therapy might be appropriate for long COVID?
I think if what you mean is just longer doses of drugs that are sometimes pulsed and sometimes combined with other therapeutics over time, then yes, that's actually what we likely see as a scenario. I mean, there's, first of all, also multiple potential drivers of symptoms in long COVID patients. So there could be patients who, for example, haven't fully cleared the SARS-CoV-2 virus from their gut and maybe have reactivation of the Epstein-Barr virus, and potentially the persistence of the virus in the gut has disrupted the other organisms in the gut microbiome, right? And so what we really see is multiple interventions that would sort of address these different sort of hits, if you will, in these patients, right? And that would require a layered approach in which you're dosing, sort of different drugs in an overlapping fashion.
Dr. Amy Proel, thank you very much for talking with us on the People's Pharmacy today.
Thanks for having me on.
You've been listening to Dr. Amy Proel. She's a microbiologist who studies the molecular mechanisms by which bacterial, fungal, and viral pathogens dysregulate human gene expression, immunity, and metabolism. Dr. Proel is the founder of the PolyBio Foundation and the chief science officer and co-founder of the Long COVID Research Initiative.
We spoke earlier with Dr. Lisa Sanders, medical director of Yale's Long COVID Multidisciplinary Care Center.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. B.J. Liederman composed our theme music.
This show is a co-production of North Carolina Public Radio, WUNC, with the People's Pharmacy.
The People's Pharmacy is made possible in part by CocoVia Dietary Supplements. This summer, keep up with your heart and brain health with cocoflavanols for a strong heart and cognitive support. Consider how CocoVia can be part of your supplement routine. More information available at cocovia.com.
Today's show is number 1392. You can find it online at peoplespharmacy.com. That's where you can share your comments about today's interviews. You can also reach us through email, radio@peoplespharmacy.com.
Our interviews are available through your favorite podcast provider. You'll find the show on our website on Monday morning.
At peoplespharmacy.com, you can sign up for our free online newsletter to get the latest news about important health stories. When you subscribe, you also have regular access to information about our weekly podcast, so you can find out ahead of time what topics we'll be covering. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you very much for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.